So thank you very much, Claire, for the introduction. I would also like to thank the organizers for inviting me to discuss this topic of recent failures in ALS therapeutic trials. And I will mainly focus my presentation on the question of clinical heterogeneity. So, as you all know, ALS is an heterogeneous disease, considering disease onset, considering motor and behavioral phenotypes, considering the balance between upper and lower motor neuron involvements, considering disease progression, and even considering metabolic profiles. But in the context of a clinical trial, this phenotypic heterogeneity is a threat. It reduces statistical power, and it leads to larger and longer trials. So most recent ALS trials have adopted restrictive participant eligibility criteria. Eligibility criteria are used to select a trial population that is more homogeneous and that will also be sensitive enough to show efficacy. So in the context of ALS, this criteria aims to select patients with no or mild respiratory involvement who are likely to survive the follow-up period, to select patients with early ALS when a neuroprotective treatment is the most likely to be efficient, and also to exclude patients with a disease course that is outside the scope of classic ALS, which means basically to exclude patients with no or very slow progression, for whom the disease progression will be too slow to capture the treatment effect, and also to exclude very fast progressors who are unlikely to survive the follow-up period. So I will give two examples of trials. The first is the CENTER trial. It was a 6-month phase 2 study which evaluated AMX 035 in a very selected ALS population of fast progressors with a disease duration of less than 18 months. And this study was positive. It met its primary endpoint by slowing a functional decline about 25% at 6 months. But we all know that the Phoenix confirmatory trial, it was a 12-month phase 3 study, which was performed in a broader ALS patient population. This study was negative, and it did not meet any of its primary or secondary endpoints. The second example is the edaravone ALS-19 trial. It was a 6-month phase 3 study which evaluated intravenous edaravone in a selected population, but on the opposite, a selected population of mildly impaired and relatively slow progressor ALS patients. And this study was also positive. It showed a slowing of functional decline by about 30% at 6 months. But we know that recent real-world data are not in favor of the efficacy of edaravone. And the recent ADER trial, it was a 12-month phase 3 trial which evaluated an oral formulation of edaravone in a broader population. This trial was also negative. It did not meet any of its primary or secondary endpoints. So two positive trials, which were performed in highly selected ALS patient populations, and both these trials led to FDA approval, but treatment efficacy was not subsequently confirmed. So, of course, this raises a lot of questions, and the first question is, what is a positive trial? And how do we measure efficacy in an ALS trial? And both these questions will be addressed by Ruben and Thomas later on. So I will mainly focus on the question of eligibility criteria, because from a clinician point of view, we often have the impression, have the feeling that we, using this criteria, we are excluding participants that would otherwise be perfect patients for a clinical trial. So I will do a quick tour of key eligibility criteria in recent clinical trials. So this is not a meta-analysis, and it does not pretend to be an exhaustive study. But I reviewed the 13 phase 2 and phase 3 trials for which we were contacted at the Clinical Investigation Center here at the Paris Brain Institute over the 2019-2022 period. So the first key eligibility criteria is vital capacity. It is a respiratory measure which is used to select participants with no or mild respiratory involvement. Vital capacity is a strong predictor of survival. There is no question about that. But there are relatively few data on which cutoff should be used in the context of a trial. In the studies that I have reviewed for this talk, most often the cutoff was set at 60 or 70%. And I found one study showing that patients with a baseline vital capacity of less than 75% had a faster disease progression. The second key eligibility criteria is the disease duration, so the time from a clinical onset of motor symptom, to the first visit of the trial, which is called the screening visit. And this criteria is used to select participants with the so-called early ALS. And for most studies that I have reviewed, the cutoff that was used was 24 months, meaning that a patient could be included in the study if the disease duration was of 24 months maximum. And some studies even used a cutoff of 18 months. And in fact, this is very short, considering that the time from onset to diagnosis is still around 12 months. And we also know that this is not really early ALS, at least from a biological point of view. And the last thing is that the riluzole trials, which to date are the only trials which demonstrated efficacy on survival in sporadic ALS patients, these trials use cutoff of 5 years. So times are changing. Now we are using non-invasive ventilations. It was not the case for the riluzole trials. But I think this cutoff of disease duration could be discussed. Another key eligibility criteria is the diagnostic criteria category. So we used the revised LS-Corial diagnostic criteria or the Awaji diagnostic criteria, which are basically based on the same thing. And all the studies that I have reviewed included or recruited participants with a definite or a probable disease, meaning that these patients had involvement of upper and lower motor neuron in 3 or 2 regions. But only 73% of these studies also included patients with probable laboratory-supported ALS, meaning that the diagnosis is supported by the electrophysiological results. And only 64% of these studies recruited participants with possible ALS, meaning that more than 1/3 of the studies did not include patients with possible ALS. So should we exclude patients with possible ALS? These patients have one region with both upper and lower motor neuron signs, so involvement in one region, or only upper motor neuron signs, but in at least 2 body regions. First, it has been shown that about 1 upon 10 patients would not meet the definite or probable criteria at death. So it is an old study performed in 2000, en 2000. But so maybe once again things that have changed because patients survive longer. But this is, I think, an important thing to consider. And the second point is that, in fact, in this diagnostic category, there are really few ALS mimics. And there was a recent study showing that the diagnostic was a false positive diagnosis of ALS in less than 3% of cases. So more than a diagnostic probability, it is in fact a category that mostly reflects a lesser spread of the disease. So, in my opinion, we should not exclude possible ALS patients, but we can discuss that later. Another criteria that is used is the total score for the ALS-FRS-R, which is the classical and validate scale used to evaluate motor function in ALS. So in the studies that I have reviewed, it was used in 45% of studies to be able to include participants with moderate involvement. And the cutoff for moderate involvement was set around 35, considering that the total score for the ALS-FRSR scale ranged from 0 to 48, and 48 is normal function. But the problem is that the ALS-FRSR is in fact a summation of 4 scales, which I have represented here. So you have the bulbar subscale, the fine motor subscale, the gross motor subscale, and the briefing subscale. Which one is this? Is it? Well, okay. So, as it is a summation of 4 subscores, in fact, identical total scores can lead to very different patient profiles. And I will give 2 examples. This first patient will have a total score of 42. He only has lower limb involvement, so he will walk and climb stairs with assistance. He will be slow when turning in bed, but other daily activities will be normal. This second patient will also have a total score of 42, but he loses his 6 points with the bulbar subscale. So he has a significant bulbar impairment, and other daily activities are normal. But this participant may require, for instance, the placement of a feeding tube during the time frame of the trial, which, of course, is a significant and important step during a trial. And finally, we have the rate of disease progression, which was used in 18% of studies to exclude very slow or very fast progressors. So this is the delta, the difference between the two ALS-FRSR scores per unit of time. It's also called the slope in the literature. And we can consider different time frames. For a clinical trial, we can consider the time frame from onset of motor symptoms to study screening, to the first visit of the trial, or a time frame between 2 assessments, and this is usually during a 3-month run-in period before randomization. But we know that the ALS-FRSR decline is not linear. And early slope will be different from the late slope during the course of the disease for more than 40% of ALS patients who can switch either to a faster or to a slower progression. And this is influenced by phenotype. For instance, patients with a bulbar onset are more prone to switch to a faster decline of the disease during the course of the disease, to a faster rate of decline, during the course of the disease. So, does slope before trial baseline predict survival? At least yes for post-onset slope. Post-onset slope is the early disease slope between motor onset and the diagnosis or between motor onset and the initial visit of the trial. And there are really several studies, numerous studies, showing that post-onset slope is an independent prognostic factor for survival. But does it predict subsequent 6 or 12-month slope? So does the slope before trial baseline predict the slope, the natural slope without intervention, during the time frame of a classical clinical trial, which is 6 or 12 months? Most probably not. In fact, there is this recent study which shows that the delta functional scale from motor onset to baseline, so to the first visit of the study, was not predictive of subsequent slope. And the 3-month run-in period, so if you keep your patient just to see what happens for the first 3 months without intervention, and you calculate the slope, this slope will not be predictive of the next 6 or 12 months slope. So I think it really raises question about the efficiency of the running periods and the qualifying running periods, the ones that are used to select participants on a specific slope. And it also shows that the ALS-FRSR decline rate, which is calculated prior to baseline, cannot be useful for stratifying subsequent progression of the functional decline. So in fact, the results seem different when we try to predict survival or when we try to predict a functional decline based on the slope of decline of ALS-FRSR. And this is also important topics for outcomes, I think. So when we combine these classical eligibility criteria, there are other criteria. Of course, I don't have the time to make an exhaustive tour of them, and we could discuss the role of weight loss and BMI in particular. But when we combine these eligibility criteria one by one with the cutoffs that I have shown, we have the feeling that we will in fact select participants with possibly a different profile. So this is a feeling, but does it work? Is it efficient? And in fact, not that much. And this is a study from Ruben's team. They applied the eligibility criteria of 38 phase 2 or phase 3 trials to their incidence cohort of ALS patients. And they showed that applying these criteria did not significantly reduce heterogeneity in survival time, and it did not reduce either between patient variability in functional decline. This is showed here. This is the variability in the whole cohort for functional decline, and this is the variability for the patients who would be eligible for trials. And there is no reduction of between patient variability. So you do not reduce the heterogeneity. But these criteria exclude the majority of ALS patients from trial participation. And in the same study, they showed that on average, almost 60% of ALS patients would be excluded from trial participation on the day of diagnosis in their cohort. So of course, the rate of exclusion is not the same. It's different for the different criteria, but it is important to see that. With this criteria, we exclude the majority of ALS patients from trial participation. And of course, this leads to a low generalizability of the results of the trials. So can we do better? The first thing, of course, is to better understand this phenotypic variability, and we need to identify the underlying biological processes. And for that, we need to perform trials, physiopathological trials, and to investigate disease mechanisms in ALS patients, and to develop innovative models for sporadic forms of ALS. And we know from genetic forms of ALS that mutations in different genes can in fact lead to the same clinical phenotype. So in fact, beyond clinical homogeneity that we are trying to capture with these inclusion criteria, what we need is also biological homogeneity. And we need to be able to test drugs in patients in whom the proposed mechanism of action is likely to be relevant. And I think the results of the tofersen study, so it was the oligonucleotide antisense study with tofersen. It was performed in a very rare form of the disease, which is linked to a pathogenic mutation in the SOD1 gene. But this study showed that if we treat the right target, we can be successful even in a clinical trial population that is heterogeneous. And this trial included fast patient, but also slow progressors. We also need to find a balance between optimizing statistical efficiency and generalizability of the results. So, of course, I am a clinician. I'm not qualified for that, and this can be also discussed later. But I think for this, we can use tools and we can use innovative ALS prediction models to be able to find common patterns of survival and of disease progression. And this is, for instance, the ANCHORS model, which I think all the clinicians in the room know. This is a model for prediction of survival, so survival without tracheostomy or dependency to non-invasive ventilation. As you can see, this model incorporates most of the well-known prognosis factors. There is not a BMI inside this model, so I think I would be also interested to discuss this point. And this ENCALS model is currently used to calculate the tricho's risk profile and to determine eligibility in several trials instead of applying the usual criteria in a cumulative manner, as I have showed previously. And there are also new models of disease progression. So this is just an example of a model which identifies clusters of patients sharing similar disease progression patterns. And if we have a look, for instance, at this cluster, we can see that for this cluster of patients, the real trajectory of the disease, which is represented by the black dots here, will be very different, in fact, after 2 years than the first year slope, which is represented here with the dashed red line. So this is, I think, something really important because we cannot base ourselves, and maybe we cannot base our outcome measures either on the first year slope because it can change in the different clusters of patients. And we can also use biomarkers, of course, and we can also discuss these topics. I will just talk about biomarkers predictive of disease progression because we have a leading candidate in the field, at least to date, which is the neurofilaments level, especially the light chain in blood, because it is easy to collect sequentially the blood. And it has been shown that the baseline serum neurofilament level predicts the future rate of motor function decline and predicts survival. And we can use these tools either to select participants with a less phenotypic heterogeneity, so to be more efficient than what we currently do in most trials. But we can also use them to stratify participants according to their predicted progression. And I hope it will allow to expand the participation in clinical trials to a larger number of ALS patients who will be more representative of the whole ALS patient population, of the global ALS patient population. Of course, everything is open for discussion, and I thank you for your attention.
So we have 1 or 2 burning questions.
Thank you, Gaelle, for this nice presentation. I have maybe a general question. Do you think that we need to keep eligibility criteria for phase 3, which are the same that the positive phase 2?
If we need to perform phase 3 trials in the same criteria that were used in the phase 2 trial.
Yeah.
My point is the criteria that we use currently are not efficient. So it excludes participants, and it's not efficient to have a biologically homogeneous patient population. So I'm not sure that we will be able to perform phase 3 trials only in selected criteria that are currently used in phase 2 trials. I think we need to work on these criteria, so maybe it can be more inclusive even for phase 2 trials, and have criteria that will select participants who are the more prone to benefit from the drug. And it was nicely shown yesterday by Laura Tseplais. I don't know if she's here. It's very interesting work which showed, I think it was in sporadic participants, that even if you have the same clinical phenotype, you may not be in the same molecular cluster in your frontal cortex or in your CSF. So I think we need to work to have a better way to select participants, and we are too far from this question of how to define a criteria from a phase 2 to go in phase 3, in fact.
So keep your question.